Hello and welcome, ladies and gentlemen. It is a pleasure to welcome you to this live webinar series entitled Key Components in the Management of Central Precocious Puberty. My name is Martin Savage and I'm speaking to you from London in the UK. And today we have the first of 3 live webinars on the topic of central precocious puberty. I'm just trying to... The title of today's webinar is Awareness of Central Precocious Puberty within the range of variations of growth and puberty in pediatric endocrine practice. Now, disorders of growth and puberty are very common, and it is our responsibility as pediatric endocrinologists to be able to identify central precocious puberty, which is an abnormality and frequently needs treating, from the wide range of variations of normal, which we see in day-to-day endocrine practice. It's my privilege to moderate today's session. These are my faculty disclosures. And today's speaker is Dr. Sasha Howard. It's a great pleasure to welcome Dr. Howard. And she is an expert in puberty, having done her PhD on the topic of genetics of puberty. And she is based at Queen Mary University of London. And as you will see, she is well qualified to talk on this topic. We have an international committee of support supporting this series of webinars. Jeff Bolton from the Child Growth Foundation, Professor Yala Ludin from Kuala Lumpur, Maria Craig, representing APES, and Maria Carolina Salerno, representing the Italian Society of Pediatric Endocrinology and Diabetes. And from SLEP, we have Dr. Hernandez, Professor Calzada, Dr. Chiesa, and then from the British Society of Pediatric Endocrinology, Dr. Tabitha Randall, and we're very grateful for their support for this series. So these are partnerships which have been established to support this educational event. And the educational event is made possible thanks to educational sponsorship provided by Ipsen Pharma. We're very grateful to you for registering for this webinar. Currently, we have 286 participants from 45 countries. You're extremely welcome, and it's great to be able to share this time with you. So the learning objectives recognize the timing and components of normal pubertal development and its variants, and describe the clinical features caused by early hypothalamic pituitary gonadal axis activation. Here you see the agenda. I will soon finish this short introduction. I'll introduce Sasha Howard. Her talk will be followed by a panel discussion, and we'd like you to enter your questions, please, on the Q&A facility that you have. There will be a post-webinar survey, and then we will complete the webinar with some closing remarks. The webinar has been accredited by the European Accreditation Council for Continuing Medical Education, and you will receive a certificate after you have completed the survey. And these are the certificates that you will receive by email from the organizers, Media. There is simultaneous translation available, so please choose if you would like to listen to the presentation in either English or Spanish. So there are now some, so now these are questions which we, of course, will address in the panel discussion. And so please submit your questions during the lecture in the Q&A section. And there is a pre and post webinar survey which will come up on the screen, and I think there are 5 questions which I will read out. So if we could have those, please. The first question is, we're going to give you 10 seconds to answer these. I can see the first question, the first true sign of puberty in girls is A, breast development, B, axillary hair, C, first menstrual period. On to the second question in just a moment. And these will be repeated after the end of the webinar. Shall we have the second question? Here we go. The first true sign of puberty in boys is pubic hair, testicular volume of more than 10 ml, or growth spurt. So thank you for completing this question. Have a few more seconds to do that. Okay, if we could then move on to the third question. Here we go. Isolated pubic hair development before the age of 8 years in a girl and 9 years in a boy is known as premature thelarchy, premature adrenarchy, or peripheral precocious puberty. So thank you for answering this question. Right lines. So this is basically rating your confidence. So please rate your confidence in recognizing the timing and components of normal pubertal development and its variants. Well, thank you for your honesty in this respect. And then please rate your competence in describing the clinical features caused by early hypothalamic pituitary gonadal axis activation. Okay, well done. So now, there we go. I'm just going to close that. So now gives me great pleasure to introduce Sasha Howard, who will address the topic of awareness of central precocious puberty within the range of variations of growth and puberty in pediatric endocrine practice. Thank you, Sasha.
Thank you so much, Martin, for that kind introduction. It's a pleasure to be here. And I'll get started with the lecture. So I have no conflicts of interest of relevance to disclose, and Professor Savage has already kindly outlined the learning objectives. So to begin, so the hypothalamic pituitary gonadal axis, or HPG axis, is a remarkable endocrine axis, my favorite, because it's active in 3 separate periods during human life. And the first is in fetal life, in utero. It's highly active and important for the correct development of the internal genitalia. And then there's a reduction in activity, and then after birth, there is a period that we call mini-puberty. And again, the axis is highly active, and we have understood more and more over the years that this mini-puberty period is also vital for future reproductive capacity. And what happens here is that the gonads, either the testes or the ovaries, are further developed and are essentially primed so that they are then able to respond to the stimuli that they receive in puberty. As we know, there's then a period of relative quiescence, so that the axis becomes very quiet in mid-puberty, in mid-childhood, and you can't measure any of the puberty hormones in a normal blood test during this period. But then at puberty, the axis becomes turned on for the 3rd time, and in a way that I will describe today, the clinical features emerge, and then the axis continues to be active through adult life. The key central driver of the HPG axis is gonadotrophin releasing hormone from the hypothalamus, and that acts to that is released from the hypothalamus and acts on the pituitary gland to stimulate the gonadotroph cells of the anterior pituitary to release the 2 key gonadotrophins, luteinizing hormone LH and follicle stimulating hormone FSH. And those then in a combined way act on the gonads, the testes in the males, to further develop the gonads and produce testosterone, and in the females act on the ovaries to produce estradiol and progesterone. And there is negative feedback from the gonad onto the pituitary and the hypothalamus. And also in females, after puberty, there is positive feedback to allow ovulation. So I'll go through these in detail, but just as an introduction, we think about the key clinical features of puberty in a boy being testicular enlargement and development of the external genitalia, with growth and enlargement of the penis and the scrotum. And later on in puberty, as a later event, the development of the potential to make sperm, spermatogenesis, and combined with that, development of the whole skeleton and musculature and maturation of the brain and emotional axes. And in girls, that's very similar in parallel. We have breast development as the first sign of puberty, with internally ovarian growth and uterine development and growth. And like sperm is a late event, sperm production is a late Like sperm production is a late event in males, menstruation and ovulation is relatively late in pubertal development in girls. And again, there's development of the skeletal system and musculature and maturation. So we know that we have the Tanner clinical stages of puberty, developed first by Professor James Tanner from the Institute of Child Health in London. And this may be familiar to many of you, but just to go through it, the stages go from 1 to 5. 1 is prepubertal, 2 is the onset of puberty, and then 3, 4, and 5 take you through to adult pubertal development. So in girls, the primary sign of puberty onset is breast development, and that's stage B2 with breast budding. In boys, the primary sign of puberty onset is Tanner stage G2, and that's defined by a testes volume of 4 mils or more. For both breast and testes, that can be unilateral, so if one breast or one testis develops in that way, that's the onset of puberty. We also have Tanner staging for pubic hair, and also not shown here for axillary hair, which is just stages 1 prepubertal, 2 some development, and 3 adult axillary hair. And this just demonstrates that there is variety in the timing of all these features, but generally speaking, they follow a similar pattern. So you can see B2 here on average is the earliest feature to develop in girls, with pubic hair a little bit later. And this is peak height velocity that occurs maybe halfway or 2/3 of the way through pubertal development, with a menarche, menstruation, as a later event. And on average, in the average girl or boy, from the onset of puberty to the end takes around 2 to 3 years. So that's similar in boys, G2 being the first event with testis volume of 4 or more. And pubic hair development is more in line with genital development in boys. Again, peak height velocity is halfway through, or maybe 2/3 of the way through puberty, but there is a wide spectrum. So what controls the timing of puberty in the healthy population? Well, we know from many studies, particularly on monozygotic twins, that it's highly heritable, and the majority of the control of the timing of puberty is through genetic inheritance from our parents. There have been some very large studies. The most recently peer review published is a genome-wide association study of nearly 400,000 women looking at their age of menarche. And they identified nearly 400 specific genetic changes that are common changes in the healthy population that are associated with timing of age of menarche. And if you put all of those signals together, they correspond to about 25% of the estimated heritability. So we can explain about 25% of the control of timing from these common genetic signals. But of course, although genetics is important, it's not everything. And we know very much from many, many studies that environment plays an important part as well. And there is important gene environment interplay. Which are the important environmental factors? Well, the most important one from research that research has borne out is body weight. So this is a study which is over 20 years old, but it's a very helpful example of the importance of weight gain, particularly during this mid-childhood period between the ages of 2 and 8. And what this study shows us is that for every increase in BMI unit, for example, from increase from 14 to 15 or 15 to 16, there is an earlier timing of puberty onset by about 1 month. And these children tend to be a bit taller in earlier childhood, but then they have less height gain during adolescence because they've already done quite a bit of their growing earlier on due to the increased adiposity driving height growth. This is a similar study from Chile, again illustrating the difference, particularly obvious between obese boys and normal weight boys, with a difference of over half a year in the timing of puberty onset between these two groups. And while the influence of nutrition and weight is very important, we also know that it's not the whole picture in terms of environmental impact. And there's been a huge amount of work beautifully summarized by this review on the impact of endocrine disrupting chemicals. These are common everyday chemicals that we might come in contact with through exposure to plastics such as bisphenol A and phthalates, or from fertilizers used to grow our food. And there's been a large number of studies, both on animals, particularly rodents, and from human epidemiological data, suggesting that a large number of these chemicals have effects, particularly in infancy and in utero, to affect the development of the HPG axis and also the timing of puberty. And when we look in animal models, some of these have a very severe effect, with even development of hyposphadias or cryptorchidism. But what's difficult is that probably every one of us is exposed to a large number of these chemicals in small dose, in different time points over different periods of our lives. And so it's hard to unpick what the differential role of these endocrine disrupting chemicals are. And there's a lot more work that's ongoing, but it's a fascinating subject. But what is clear is there's been a secular trend in the timing of puberty. So if we look from the end of the Second World War, at girls' onset of puberty B2, or boys' onset of puberty with testicular volume of 4 mils or more, there's been a gradual decline in the age, and that's through many different countries. So most likely over this first 50-year period, that was due to nutrition, with people generally having improved nutrition. And then from around the 1990s, we see the effect of too much nutrition, so overweight and obesity, intertwined with, as I mentioned, endocrine disrupting chemicals. But there's also evidence from studies of the impact of other features, such as the impact of adoption or psychosocial distress or neglect on timing of puberty. But on a population level, probably body weight is the greatest driver. So we described that the spectrum of puberty onset is variable in the healthy population and follows a near normal distribution. And as clinicians, we define either precocious puberty or delayed puberty statistically. So that if you have onset of puberty, which is less than 2 standard deviations earlier than the average age in the population, so that's 8 years in girls or 9 years in boys, you're defined as having precocious puberty. And at the other end of the spectrum, if you are late, if you are more than 2 standard deviations later than the average, so 13 in girls or 14 in boys for onset of puberty, then you'll be defined as having delayed puberty. But don't forget that events like menarche are even 2 years later than that. So that means that about 2 in every 100 people will have either precocious or delayed puberty. And what's the impact of that? Well, we know from very large studies such as UK Biobank of hundreds of thousands of individuals that on a population scale, early puberty is associated with significant risk of endocrine cancers, type 2 diabetes, cardiovascular risk, and other psychosocial risks. And in turn, delayed puberty is associated with similar overlapping features, particularly if untreated: low bone density, loss of adult height, more psychosocial impact, and potentially early menopause and andropause. So that's not true for every individual with early or delayed puberty, but it's important overall in terms of population risk. But we're today concentrating on precocious puberty, so let's go to that. So as I've mentioned, the definition of precocious puberty is breast stage 2 in a girl, so that's the onset of breast budding, the first sign of a breast bud, which can be unilateral before the age of 8. And in boys, it's the development of one or both testes being 4 mils or more under the age of 9 years. And we know that for most patients with this true definition of central precocious puberty, although their puberty is happening abnormally early, it then follows a relatively normal course. And there's been a lot of work, this is recent data, suggesting this is much more common in girls than it is in boys. And that's an interesting phenomenon. We don't really know why. We don't know if the axis is more sensitive in girls, or it's just that girls present more because breast budding is more obvious for a parent to detect than a slight increase in testicular volume. It's rare to find an underlying brain injury, insult, or tumor, but it's important as clinicians to be aware of the possibility of this and to ask appropriate history questions and examination to detect the potential for example, a space-occupying lesion. It's also rare but important to remember that central precocious puberty can be associated with several genetic syndromes, which I don't have time to go through in detail today, but to ensure we're taking a full history, asking about learning difficulties, behavioral abnormalities, and other health care needs of this patient. But what we have understood a lot more recently is underlying genetic diagnoses for central precocious puberty. So we used to say that the majority of central precocious puberty was idiopathic, which essentially meant that we didn't know what caused it. But we've discovered more and more that these cases are due to genetic changes, often inherited from parents. The first genes that were identified were the kispeptin gene, KIS1, and its receptor. And you may have heard of kispeptin. It's a very important stimulatory signal to GnRH in the hypothalamus that drives the onset of puberty. But it's actually extremely rare to find mutations in either KIS1 or KIS1R in patients with central precocious puberty. Much more common are variants in a gene called McCorin-3 that was identified about 15 years ago. And some cohorts find mutations in this gene in up to 40% of familial cases of central precocious puberty. McCorin-3 acts as a puberty pathway inhibitor. So if you have a mutation that leads to a loss or reduction in function, that then allows onset of puberty at an earlier age. Typically, these children aren't extremely early. They tend to be around 6 or 7 when they enter puberty. Another gene more recently identified is DLK1. That's much rarer, but from a clinician point of view, it's important that if a patient has a DLK1 variant, we need to screen for associated metabolic derangement, because it's been observed that these patients often either have insulin insensitivity or lipid derangement. It's also important to know that these genes are maternally imprinted. So when we're asking about family inheritance, this will be inherited from the father's side. You can ask about dad's timing of puberty, but often men don't recall as well as women because there's not a clear event such as menarche to remember. So we then ask about the father's mother's timing of puberty, the timing of menarche, and if he has sisters, about their age of menarche, and that can be a clue. Okay, so that's central precocious puberty, and we'll talk more about that in a minute. But I want to move now to pubertal variants that are not central precocious puberty, that are what we call benign variants, but we find hard often to distinguish those from a diagnosis of central precocious puberty. The first one of these I'm going to mention is early pubic or axillary hair. That's grouped together and called premature adrenarche, or sometimes premature pubarche. Pubarche means development of pubic hair. It occurs in boys and girls. And the most important thing is it's not associated with signs of true puberty. So in a girl, there will not be breast increase. And in a boy, there will not be testis volume increase. And that's because in premature adrenarche, it's driven by the release of hormones from the adrenal gland, from androgens. There is not activation of the HPG axis. There is not increase in estradiol in girls, nor increase in testosterone in boys. But you might see a mild increase in height velocity and some other associated features as shown here. So I've mentioned pubic hair and axillary hair. You can have one or the other. There may be some skin changes. Often parents report body odor. That's often what they notice. Acne is rarer, but it is possible. And these are features which are very commonly seen in young children, even from the age of 5 or 6. And this often presents to our clinic. And it's important to differentiate this from central precocious puberty, because you don't need to investigate them in the way you do for central precocious puberty, and they don't need to be treated in the vast majority of cases. One thing I will emphasize, and I'll emphasize it again in a minute, is that the important differential diagnosis of premature adrenarche is late onset, so non-classical congenital adrenal hyperplasia. So that's not salt wasting, but the non-classical variant that can present with similar features like this. Typically, bone age is very advanced, the height velocity is increased, and these features are quite pronounced, but it can be subtle, and it's important to consider this when you see a patient with premature adrenarche. Another important variant of puberty is premature thelarche, and I'm going to talk about that with this other similar, slowly progressing early puberty. So we see this in girls as development of breast buds, and it's obviously very difficult to know if that's a mild benign variant or is actually central precocious puberty. Typically, you don't get the biochemical changes of central precocious puberty. I'll go through those in a minute. And typically, it's very slowly progressing. So menarche will occur not 2 or 3 years after breast development, as I explained, but more than 5 years. And therefore, the child will have menarche at a normal age, and you will not need to intervene. But these children do need careful assessment and monitoring. So just to go through the typical features that will help you differentiate from premature thelarche and central precocious puberty. It may help to think about premature thelarche as a hangover from mini puberty. In mini puberty, as I described, the axis is active. In girls, there will be a rise in estradiol, typically with a high FSH, without a high or LH, or at least the FSH will be more elevated than the LH. And that can drive development of small breast buds. We see this in little infant girls, even up to the age of 2 or 3. But in some children that persists, and they may even present age 5 or 6 with this isolated breast bud development. It tends to be non-progressive, so they don't progress to Tanner stage B3, B4. As I said, FSH tends to be high if you test it, either if you do a basal test of gonadotrophins just in the clinic, or if you give the classical GnRH stimulation protocol that most hospitals will have a protocol for, you will see a rise, particularly in FSH, but not in LH. Additionally, growth will typically be normal with a normal bone age. So if you do a bone age X-ray, they won't have particularly advanced bone age. And if you do an ultrasound of the pelvis to look at the uterus, in isolated thelarche, they will have a typical prepubertal uterus. So that's a small size, but also the shape will be tubular, like a long tube. That's in contrast to if you have central precocious puberty. If you do these investigations in a child with central precocious puberty, the bone age will be typically advanced, at least 1.5 to 2 years, sometimes even more. And if there has been development of central precocious puberty for more than a couple of months, you'll start to see changes in the uterus because the uterus is responding to the circulating estradiol. And the uterus will get larger. And instead of being tube-like, it will become conical with a larger AP diameter and a shorter cervix. And eventually the endometrium will also thicken. So these can all be helpful to distinguish. And it is important because typically premature thelarche, as I mentioned, doesn't require treatment. It doesn't lead to early menarche. Whereas central precocious puberty, it's not that we treat in everyone, and you're going to have 2 more webinars going into detail about when to treat and how to treat, but we would at least consider treating in children with central precocious puberty. I'm going to briefly mention peripheral precocious puberty, briefly because it's extremely rare, and the vast majority of children you'll see will have either central precocious puberty or these kind of pubertal variants that are mostly benign. But I'll mention it because it's important to consider and to diagnose. In peripheral precocious puberty, the sex steroids, so estrogen in females and testosterone in males, are not produced from the pituitary. So you will have a low LH and FSH. Indeed, the sex steroids will exert negative feedback and further suppress them, so they may be undetectable. Instead, testosterone or estradiol are produced either from the gonad or from the adrenal gland driving androgen production, or from an exogenous source. McCune-Albright is often a syndrome that we consider with peripheral precocious puberty. Again, I emphasize it's extremely rare, but it is to be considered, especially if the patient has cardinal features. Some of these are shown here, such as fibrous dysplasia, and these particular cafe au lait patches, which are large macules with this very irregular edge known as the coast of Maine, because the state of Maine in the USA has this very irregular edge. It's got a complex genetic cause. It's a mosaic condition. So not every cell in the body will have the mutation, but it occurs after the zygote has formed. The mutation is in the GNAS1 gene. And if the mutation occurs in cells of the ovary, it will lead to the LH receptor in the ovarian cells being constitutively active. That means it's turned on and it drives the production of estradiol. Typically, these children have very early precocious puberty at the age of 2 to 3 years, and they need very particular management in a tertiary or even quaternary center. So please don't be terrified by the complexity of this diagram. It really just serves to summarize what I've said, and I'll take you through it. So this is for precocious breast development in a girl. This is what we use in our center, but you'll see other flow diagrams in a similar way. So just to summarize what I've mentioned, precocious breast development in a girl before the age of 8. You're going to think about associated signs of puberty, about bone age and height velocity. If everything is reassuring with a normal height velocity, bone age, and no associated signs of puberty, and the child is very young, 1 or 2 years of age, it's probably premature thelarchy and you're just going to monitor. If the child is a bit older, you may consider doing the tests that we've discussed. Pelvic ultrasound to look at the size of the uterus, measurement of the gonadotrophins and estradiol, that might be basal, that might be basal, or it might be on stimulation testing. And if these are reassuring, then you will also diagnose premature thelarchy and follow up. However, if you diagnose central precocious puberty because of a high basal or stimulated LH, and you see that there is a pubertal changes on the pelvic ultrasound, then it's worth considering CNS imaging, so an MRI of the brain and pituitary, and you may rarely diagnose an organic cause which will need specific etiological therapy. Or you may diagnose familial or idiopathic central precocious puberty, and as I said, there will be further webinars on the treatment of that. Much more rarely, you may see peripheral precocious puberty with low gonadotrophins despite high sex steroids, and then you will go on to do further studies. I would suggest you get advice from a tertiary center looking to see whether this is McCune-Albright or production of either sex steroids or androgens from a source, and consider congenital adrenal hyperplasia and do the classic investigations that we all know for that condition. Very similar in a boy, if you see precocious genital development with development of a testes, one or both that is 4 mils or more, a rare condition that we see rarely in the developed world because we have screening for hypothyroidism, but is possible to see, is macroorchidism due to hypothyroidism, and that will obviously need treating. There is also some rare genetic conditions that cause this, and you would discuss that with your genetic support. But as we've discussed, if you find the classical picture of central precocious puberty, bilateral enlarged testes, high sex steroids, high gonadotrophins, you will absolutely do an MRI brain in a boy to diagnose or to exclude organic central precocious puberty. I would just say that the historical literature tells us that in boys with central precocious puberty, you will find a brain lesion very commonly up to 75 to 80%. But the more recent literature suggests that that's very overinflated in terms of the percentage, and it's much rarer, more like 10%. But I would still encourage you to do the MRI brain. And then, of course, if it's idiopathic, familial, central precocious puberty, or sporadic central precocious puberty, you will treat. Much more rarely, if you have either a unilateral or a bilateral enlarged testis with high testosterone but low gonadotrophins, you will need to go through further investigations with your tertiary center, looking to see whether there is production of testosterone or HCG from a tumor in the testes or an ectopic site or an adrenal tumor or CAH. And then I want this to be very clear in your minds that pubarchy, so adrenarchy, which is pubic or axillary hair, does not represent activation of the HPG axis. This is to do with androgens from the adrenal gland. You will make sure that you're not seeing central precocious puberty. You will look at height, velocity, and bone age. And as I mentioned, you will make sure that you have not missed a late presentation of non-classical CAH. Very rarely, in extreme cases, this can be the initial presentation of a virilizing tumor or of peripheral precocious puberty, but the vast majority of these patients with a little bit of pubic or axillary hair and some mild bone age advancement will have this mild condition of premature adrenarchy that doesn't need treating and just needs follow-up and monitoring. So just in conclusion, I'd like just to make it clear that puberty is not just activation of the hypothalamic pituitary gonadal axis, and of course that's very important and that's how we define true puberty, but in conjunction there are two other axes. There is the adrenal androgens from the adrenal cortex, and sometimes that happens before true puberty and we get this condition of adrenarchy, which I've described. There is also, very importantly, a close link between puberty and growth during adolescence, and the GH-IGF-1 axis will drive the puberty growth spurt. This is the Prada orchidometer, named after Professor Prada from Zurich. And it's useful to know that the start of puberty growth spurt in boys is typically when they achieve a testis volume of about 10 mils. And the peak height velocity, so their maximum height velocity, is typically around 15 mils. You can see, and many of you will know this, that peak height velocity is later and higher in boys. And that is the reason why typically an adult male will be about 13 centimeters on average taller than an adult female, because they grow faster for longer. The other useful bit of information, if you see a girl who's had her menarche in clinic and worried about how much more she might grow, is that on average, girls will grow about 5 centimeters after their first period, although obviously there's a range from about 2 to 10 centimeters. So this is just a schematic. I've been through all of this. Precocious puberty, you must consider growth and bone age. There will be normal variants due to either premature thelarchy or premature adrenarchy, but one must be alert to potential pathological variants, either central precocious puberty or peripheral causes, which might be androgen-driven or estrogen or testosterone-driven. So the take-home message is that we remember that in the healthy population, puberty is variable, and that both genetic and environmental inputs affect the timing of puberty. And that in healthy puberty, it's not just the hypothalamic pituitary gonadal axis, but also the adrenal and growth axes that play an important role. And that's why, as clinicians, it can be very difficult to distinguish between benign variants of puberty from those conditions that are significant and pathological and need thorough investigation and treatment. Thank you for your attention, and I'm looking forward to some discussion with further questions.
Great. Thank you so much, Sasha. A beautiful lecture, very instructive, very clinically orientated, and extremely helpful. Now, actually, we have lots of questions, and so I'm going to ask you if you could possibly answer relatively briefly so we can get through as many as possible. Right. Now, of course, it's a little bit frustrating because I don't know where the questions are coming from, but nevertheless, till what age does central precocious puberty need to be followed up until transfer care to an adult endocrine team, if
I
that
think
is
that's
appropriate?
an excellent question. I am mindful that you'll have webinars on treatment, but I think it's an important point to note that we shouldn't treat and then discharge when treatment stops. Absolutely not. We need to be certainly following up these girls to make sure that they develop menarche, that they go through menarche, and that they're having healthy, regular menses. It has been very well observed by many groups that central precocious puberty is associated with difficulties with periods, with menorrhagia, and with PCOS and PCOS-like phenotypes, with girls being overweight, with insulin resistance, lipid abnormalities. So it's important to talk to our patients about that and to make sure that we're monitoring them carefully. I don't normally transition these girls to adult care unless they have a particular phenotype, but we need to look after them certainly for a good few years after they've had their menarche.
Okay, thank you. Do we need to do genetics for girls diagnosed with idiopathic central precocious puberty? In other words, is it relevant to therapy or prognosis, etc.?
Thank you. So it does vary whether you can do genetics or not. So in the UK, we do not have on our National Health Service the availability to do genetics for central precocious puberty. I hope that in the future there will be a panel for that, but I think it varies in different European countries and what centre you're in. I would suggest that if it's available, particularly if it's a familial picture, if you've asked the question and either mum or dad, or as I said, dad's relatives have early puberty, then I would certainly think that was useful. And as I mentioned, particularly with DLK1 variants, there is an associated metabolic phenotype, and we should be particularly looking at those girls and boys for insulin access and insulin sensitivity and lipid monitoring.
Okay. What factors do you think are responsible for the increment of central precocious puberty during COVID?
Yeah, it's a really interesting question. There's been a lot published on that. I think it's probably a lot of different factors. I don't think it's to do with the COVID virus itself. The evidence hasn't pointed to that. I think it's there's a large influence of the further increase in overweight and obesity in the population following the COVID pandemic, with children being shot at home, with less physical exercise. And generally there has been, certainly the UK data points to a big problem with a shift in percentage of children that are overweight or obese. Having said that, there is a bit of conflict in the data, and some studies suggest that's not the whole picture. So we're interested in things like screen time. Certainly in rats, if you expose them to blue lights from screens such as tablets and iPads, they have a different timing of puberty. So I do think we should be mindful of how much screen time our children have. And then finally, there's also the impact of psychosocial. I mentioned that children who are adopted or have difficult upbringings with neglect have impact on the timing of puberty. And I think it was a very stressful period for a lot of children.
Thank you. Sometimes there is premature thelarchy with bone age advancement without ultrasound changes, and the breasts can be more than standard stage 2. How do you follow these girls? And is there some clue that makes you offer treatment?
Yeah, I think it's really difficult. I mean, for the purposes of a lecture like this, I think it's very helpful to, make clear distinctions between diagnostic groups. But of course, as clinicians, we know that it's a spectrum.
Yeah.
And I think in my practice, if I'm very reassured with what I see, then I tend to do minimal investigations and monitor for a certain period of time. And if there's no progress, then I might even discharge. Whereas at the other end of the spectrum, if I'm very clear there's central precocious puberty, then in a way it's easy to know what to do. I think the ones in the between are very difficult. The more breast development, the more bone age and advancement, in my practice, the more investigations I will do. So I will tend to do basal, and if the basal is not clear, so if the basal is suppressed, I will do a GnRH stimulation test and help that to distinguish whether there is true biochemical definition of central precocious puberty, so an increase in LH more than 5 international units. I will also not do a pelvic ultrasound in every girl with premature thelarchy, but in those with more advanced breast development, with more advanced bone age, then I will use a pelvic ultrasound. And I do find that quite useful, particularly in terms of endometrial thickening. So, if I can see that the uterus is enlarging, particularly if it's getting to sort of 50 millimeters in length, and the endometrium is getting thicker, 5, 6, 7, 8 millimeters, then I'm definitely concerned that that's suggesting that menarche is on its way, and I'd be much more inclined to treat.
Right. So I just pick up on one point. You said if basal LH is suppressed, I mean, in some situations, can that still be compatible with central precocious puberty?
Yes, and perhaps, I'm sorry, maybe I should have gone through that in more detail, but it depends where you work and what your assay is.
Right.
So, we think about a test being a yes/no, but of course it's not. All tests have thresholds of sensitivity and specificity. If your basal LH is less than 0.3 international units per litre, that is reassuring that the child doesn't have central precocious puberty, but it's not 100% sensitive. So there will be some children who will have central precocious puberty, but their first basal LH will be less than 0.3. So if your clinical concern is still very strong, then even if you have a basal LH of less than 0.3, you may still want to do a stimulation test.
So a stimulation test will distinguish.
A stimulation test is much more sensitive than a basal. So if your stimulation test shows that your LH stays below 5 international units per litre, that is very reassuring.
Right. Okay. Brilliant.
And not all assays go down to 0.3. So a lot of places, all you know is your LH is less than 1, which is actually really not that helpful. And there are lots of children with central precocious puberty where their basal LH is less than 1.
Okay, that's very helpful. Do you perform MRI in girls with central precocious puberty between the ages of 7 and 8?
Such a difficult question. We still do in our centre because that's what the European guidelines say.
Yes.
Having said that, we pick up very, very, very few, if any, lesions of significance if there is no other features to suggest. So if the child is otherwise entirely well with an entirely normal history and no concern at all about headaches or vomiting, no changes in behavior or learning attainment, and they are over 7 when they have breast development and they are a girl, I think, that's not what the European guidelines say, but I think it is reasonable, and there is a body of evidence to suggest that not all of those girls need an MRI. I would do an MRI in every child under 7 who presents with central precocious puberty, every girl under 7 who presents with central precocious puberty, and every boy who presents with central precocious puberty.
Right.
Exactly.
In premature adrenarche, often bone age is advanced. How many years can be without alarming us?
Yeah, difficult.
Question from Peru.
Yeah, it's a really good, difficult question. And we all know, again, that bone age is not a perfect test. It varies. So in our centre, we get both TWA and Grulich and Pi, and there may be 6 months discrepancy between those two at the same chronological age. So that's the first thing to say. The second thing to say is there is no absolute threshold at which I am totally reassured or totally worried. But to try to help, I would say that 1.5, 2 years at a maximum, I'm not too concerned. Certainly, if they're 2.5 or 3 years advanced, I am much more concerned. And 2 to 2.5 years, you know, I'm still a bit worried. And I wouldn't just do one bone age. You know, I wouldn't do one bone age and do nothing. I would do a bone age. And if I wasn't treating and I wasn't thoroughly investigating, I was monitoring, I would do another bone age in 6 or 9 months' time.
Right. Okay. There's some more questions. Is macroorchidism responsive to thyroxine therapy? I guess if it's associated with hypothyroidism, it would be. So
yeah, I mean, it's incredibly rare to see that. But yes, the classical cases by so Grumbach syndrome suggests that it is
in the old days. In the old days, we used to see it. Can teachers at school detect central precocious puberty?
My feeling, I don't have literature on this, but my feeling is that the understanding of the timing of puberty, even in very educated people, is not that good. And often people don't realize, unless it's extremely early. The other thing that we get a lot is quite overweight girls. Not necessarily obese, but overweight, who have quite a lot of fat deposition over their chest. And that can be very difficult because there are lots of little girls who appear to have little breasts. But actually, if you palpate as a clinician, there is no breast tissue there. There is no ductal mammary tissue. It's all fat. And that's very difficult for a non-clinician, a non-pediatric endocrinologist to distinguish.
You have to palpate with a flat hand. I just mentioned that. If you dig your fingers in, then it's very difficult. But if you palpate with a flat hand, you can usually detect if there is actually a breast bud there. Well, you're doing brilliantly. How long does mini puberty last after birth?
So in boys, it doesn't last as long. Studies and it doesn't suddenly stop, so it wears off, but about 6 to 9 months, maybe 12 months, you've then got a return of LH, FSH and testosterone to the undetectable levels. FSH sometimes lingers a bit. It's longer in girls, so it might be up to 1.5 or even 2 years in girls, particularly FSH. So LH and estradiol come down earlier in girls, but FSH may still be a little bit higher than the mid-childhood up until 2 years of age.
Okay, I think we've covered, there are some questions which I think will be addressed in the second and third webinars. So I think you've done extremely well. We've covered just about everything. So I'd like to thank you, Sasha, very much indeed. Extremely clear and instructive presentation, and I'm sure many people have benefited from it. Thank you very much indeed.
Thank you for having me.
So let me just remind everybody who's watching that the second webinar is on the 20th of October, will be entitled Early Identification of Central Precocious Puberty Patients Requiring GnRH Analog Therapy. So there will be more explanation about investigations and so forth in the children who specifically do require therapy. And the third webinar will be on the 9th of November, choice and initiation of GnRH analog therapy for central precocious puberty, concentrating on long-acting GnRH administration. So thank you. These are the certificates which you will receive. We ask you please to complete the post-event survey, and having done that, you will then receive your certificates by email. People are posting thank yous, which is very encouraging. And there we are. And just from the organizers, thank you for organizing this seminar. And from our point of view, we very much enjoyed sharing this time with you. Disorders of puberty are highly relevant and a cause of major concern within a family, and therefore need to be taken seriously. And therefore, we feel that this topic of central precocious puberty is highly relevant from a clinical point of view for those of us practicing pediatric endocrinology. I'd like to thank you again for logging in, sharing this time with us. Thank you for your questions, which have been very helpful. And thank you again to Sasha for a lovely presentation. And thank you to Medea for organizing this webinar, and to the educational grant from Ipsen for supporting it. Thank you very much. We look forward to seeing you again on the 20th of October. Thank you and goodbye.